Okay, well, welcome everyone. Looks like I get to talk to you today about a chamber of the heart that's often neglected by cardiologists. So without further ado, I'll be speaking on the assessment of RV function using CMR. I do want to give a disclosure. I will be talking about off-label use of gadolinium for delayed enhancement purposes. And there's actually two wonderful articles by Dr. Haddad et al. That discuss right ventricular function and hemodynamics and how it relates to pathophysiology overall. And I encourage everyone to go through these articles at least once, because what you think you might know about the heart and circulation based on the left ventricle is very, very different when it comes to the right ventricle, because the way the right ventricle behaves is very, very different, and I'll go into that in just a bit. So what exactly is the right ventricle, and what does it do? Anyone want to take a quick guess or quick answer? Okay. Sir William Harvey gave a very classic description of it in his treatise on the circulation of blood. He described it as the right ventricle may be said to be made for the sake of transmitting blood through the lungs, not for nourishing them. So he recognized back in the 1600s that this was a chamber that collected blood and sent it to the lungs for oxygenation purposes. So what exactly does it do? It receives systemic venous blood, so it receives blood from the IVC, SVC, and the coronary sinus, sends it to the pulmonary artery, and assuming that everything is continuous, that there are no shunts, there's no abnormal connections, RV stroke volume should ideally equal LV stroke volume. So pulmonary circulation should equal systemic circulation. In terms of its anatomy, it's bounded in different parts. There's at least one part that involves the tricuspid inflow, you can see here. And then it's also bounded on the other side with the pulmonic valve. The myofibrils are arranged in parallel with each other, as you can see here. And that lends it to a very unique form of squeezing action. In terms of its shape, it's often described as crescentic on cross-section or short axis views. It's also described as triangular on side views or long axis views. And the reason why this becomes important is because when we try to image it, it doesn't lend itself well to imaging planes. It has a separate inflow and outflow that are completely off plane with each other, and so it's very hard to capture the two on a single view.
Eric,
yes,
question. Sir. You know, with this new model of the heart having spiral fibers that, you know, that does the myocardial fibers of the RV exclusive to the RV, or are they shared with the RV? In that spiral model that you showed a beautiful picture there. So, are the myocardial fibers of the RV only of the RV, or there are some fibers that are crossing on both chambers?
There is some shared, but the LV is in general a completely separate arrangement in terms of myofibrils. The LV is actually organized in sheets that rotate within the layers. So the arrangement of myofibrils actually changes in the LV, whereas the RV it tends to be a little more uniform. And if you see on echo and MRI, there's actually a little bit of separation as well between the RV and LV in terms of myofibril arrangement. But you would know better than I do.
It's been something that has always been a curiosity of ours, because even years ago, for example, I think Dr. Zarbi showed way back, I think he was a fellow there, that if you have hypertension, just plain hypertension, and you had some diastolic dysfunction of the LV, you had some diastolic dysfunction of the LV. It was subtle, but if you look at people that were controlled normals, people who have just hypertension, they were not sick, and they had changes in the E to A ratio of the mitral valve. They also had it on the tricuspid side.
That's interesting.
So there's a lot of literature that shows that when the LV is affected by something, the RV is affected too. Not because of pulmonary hypertension. So that has always been one of my, okay, do they share kind of fibers so that when one is affected, the other one shows signs, subtle signs of being affected too?
I actually do cover that in a bit because you're right, there is some interdependence between the two chambers. And so what affects the left ventricle usually ends up affecting having some effects on the right ventricle and vice versa. In fact, our common understanding of the right ventricle now is anything you do that affects the right ventricle will also affect LV function. So you're absolutely right. Okay. But as I was saying, the inflow and the outflow are often in separate planes. There's no uniform geometric assumption for volumes, unfortunately. So when I say geometric assumptions, for the LV, for example, we assume it's a semi-ellipsoid. And so we can use very clear, defined mathematical formulas to quantify it. The RV, unfortunately, does not lend itself well to that kind of quantification. And unfortunately, in patients will be patients. Every human is a little bit different. And the right ventricle is highly variable in location and orientation from person to person. So in terms of the chambers, there's been a lot of focus placed on the left ventricle, but the right ventricle is kind of like a second child. So while the left ventricle, we've described a lot of amazing things and have come up with different parameters on how to assess it, including down to diastolic function, which Dr. Naga has written extensively on. The right ventricle, there's a lot we know and don't know about it, and we're still trying to elucidate. This is a table from the first part of Dr. Haddad's article, which compares the LV and RV. And I won't go into great detail here, other than to say it's clear that the RV functions very differently. RV is viewed as being very well adapted to volume overloaded states, changes in volumes, whereas LV is better adapted to sudden changes in pressure. So it's able to accommodate pressure loads better. Now, when we talk about the RV structurally on imaging, this is more for the fellows. Things that we look out for, the most defining feature is a tricuspid valve. The tricuspid valve is a little more apically displaced compared to the mitral valve. It's usually less than 8 millimeters per meter squared. If it's more than that, then we suspect Epstein's anomaly. There's usually the presence of a moderator band. There's usually there's usually 3 or more papillary muscles involved. And tricuspid valve usually has its papillary muscles inserted on the septal side. And of course, a common answer that's given when you ask medical students in residence how you tell the RV from LV is that the RV is a little more trabeculated, but that's not the strict definition of that, because you can get trabeculations in what situation? LV non-compaction. Now, in terms of RV mechanics, we don't do a very good job in terms of visualizing contraction as well, especially on short axis views, and that'll become much more apparent when I show those views. But in terms of the contraction sequence, it's not as uniform compared to the LV, whereas in a normally conducting LV system, everything squeezes and comes in together, whereas the RV actually has sequential activation. You'll actually see the inlet activate first with the apex, and then the outlet and infundibulum squeezes 25 to 50 milliseconds later. It does have effects, as Dr. Quinones pointed out, in that it has effects on the hinge point and also on the LV septum. In terms of its hemodynamics, the pulmonary vasculature is, of course, very different from the systemic vasculature. Systemic vasculature is usually described as very high resistance. There is great distensibility to the aorta, but there is a higher resistance system because multiple organs are involved. Whereas the pulmonary vasculature is designed to be low impedance, highly distensible. Why? Because it's trying to move large amounts of blood flow through to get oxygenated. It also has a low peripheral pulse wave reflection coefficient, so it tends to have a more rounded contour in terms of its shape. And it also has a phenomenon known as a hangout interval. So whereas relaxation could have already begun in the RV, and there may be a transient to negative pressure, as you can see here. where the pressure actually drops below that of the PA, the valve actually stays open for just a little bit longer period before it actually snaps shut. And so that's why it's described as more of an inertia volume-mediated chamber versus the LV. And we'll go into this as much detail. But in terms of ventricular synchrony, ventricular interdependence, that might partially explain why there are other relationships between the LV and RV beyond simply that of the pulmonary vasculature as well. But it still obeys similar rules with preload, contractility, and afterload that we see with the LV. In terms of using CMR versus echo, echo does, unfortunately, on the two-dimensional side, not produce reproducible RVEF. Fractional area change is usually the number that's reported, but there are some problems with that because the scan plane can change based on the sonographer. And so there is a little more variability with that technique. However, in the advent of 3D echo, it's now being recognized that 3D echo is potentially comparable to CMR in terms of reproducibility. And so, so that's why in the new 2015 chamber guidelines, it's now recommended as a potential thing to be reported, recognizing, of course, that there are differences between patients of different age and also gender. And there's some research from MESA suggesting possible ethnic differences as well. So why use CMR? CMR allows us to see quite a lot. We can get a large field of view, and so we can see not only things going on inside the heart, we can see things going on outside the heart and see other structures, such as, of course, the lungs, the diaphragms, and catch anything like masses, and the pericardium as well. We can prescribe an unlimited number of imaging planes, so we can set planes whichever way we want. And there's a possible new technique down the road, which I'll talk about, which offers some exciting possibilities. It also provides superior image resolution. So while there may be poor acoustic views on echo, CMR doesn't suffer as much from that limitation. And it also allows for tissue characterization. So we can actually describe fibrosis, inflammation, scar, fat, and thrombus using CMR techniques. It's also, and the biggest draw to CMR is that it allows for highly reproducible volume quantification. And I'll go over the data behind that. Okay. So how do we do it? I'm just going to go through very quickly how we acquire cardiac MRIs. We usually start off with a standard axial, a transverse view of the heart, get a pseudo 2, pseudo 4, and then get a short axis stack through the entire heart oriented to the left ventricle. From that, we can also get our standard long axis views of the left ventricle, so our 4, 3, and 2. And then from using the 4 and the combination of short axis views, we can actually prescribe some unique views that give us a 3-chamber RV view, so we can see the inflow and outflow. And when we orient it a little bit differently, we can also get an inflow view, a 2-chamber view as well. We can also get an outflow view by basing it off of the RV 3-chamber. And some literature describes using a potential axial view as a correction. So what can we tell? We can tell quite a number of things with visual assessment. Let's see if this will play for me. We can see visually that the RV has inward motion and comes in towards the septum. We can tell if the function of the course is severely depressed, as can be seen here. We can also see if there's RV dilatation. Just like with echo, we can see if there's apical dominance and larger diameter sizes as well. We can also appreciate RV hypertrophy, and shown here is a patient who very much has pulmonary hypertension. You can see the septal flattening that's already bad in diastole and worsens with systole. And you can also see the RV wall thickness is clearly more than 5 millimeters, suggesting significant RV hypertrophy. We also give, as part of our protocol, patients IV bolus contrast, and we perform an MRA with the contrast bolus, both in the arterial and the venous phase. Why is this important? Because when you give it in the arterial phase, normally we should not see any contrast refluxing into the hepatic veins and IVC. When we see that, that's suggestive of increased right atrial pressure or significant tricuspid regurgitation. So this is equivalent of a hepatic venous Doppler reversal that you see on echo. This is venous phase showing everything lit up for just for comparison. We can also do some semi-quantitative methods. We can describe wall motion similar to echo. In this case, we adopt the nomenclature that's described by Rutsky et al. In the initial right heart recommendations, right heart assessment recommendations. And we describe it in terms of an able component, a lateral free wall component, and also basal and inferior component as well. And as you can see here, we can also describe hyperenhancement, which I will go into in more detail with a case example. In terms of volumetric analysis, we have no geometric assumptions, and so we can apply Simpson's method to the short axis stacks that you see. And by doing so, we can get a set of stacks and sum this up to get a volume. We can repeat this in end-diastole and end-systole to get a stroke volume and get ejection fraction from that. In addition to that, we can actually do phase contrast angio, where this is kind of the equivalent to echo Doppler, where in this case we set a scan plane perpendicular to the pulmonary artery flow, and then we can actually measure the flow over that time period over a cardiac cycle and get the stroke volume coming out of the pulmonary artery. This acts as a second check for RV stroke volume in patients without significant tricuspid regurgitation or pulmonic regurgitation. And this also allows us to perform additional quantification in the setting of valvulopathy like significant TR or PI.
Why do you have so many peaks?
I'm so sorry?
You see a big peak of flow and then you see smaller clouds. Are these real? Are they there?
That's a good question. There are a couple camps of thoughts about that. One is because there is a low wave reflection coefficient. We could be seeing some phenomena of that, but in this case, this is for flow, and in the later part of early diastole. And so this could also represent the distensibility of the pulmonary artery continuing to contract, and that's what we're seeing.
So you're showing the flow between two QRS complexes here?
Yes. This is a R to R. So the quantification method is described as highly accurate, highly reproducible. Excuse me. There's low variability. In fact, interstudy differences are of only 5 to 6%. So inter-visit. There's also high inter-observer reproducibility as well. And so this allows us to do accurate assessments that may impact decision making about PI and TR, and also allow us to do long-term surveillance measurements on patients.
Is this the real-world experience with the variability in measuring RV that is representative of real-world experience, 5 to 6% variability in RV volume? Like
Yes. Although I think that might improve now that we're in the era where we can actually not only look at short axis stacks, but actually confirm planar locations on corresponding long axis views. But that would be interesting to try to revisit. Okay. There are reference values. Dr. Massera and company in the UK have published literature on pretty much all the chambers of the heart in healthy normal subjects. But to note that there are differences between male and females. Men tend to have a little larger volume compared to women overall. And there's also differences in age. as we age, and this was seen very well in the MESA cohort as well, which confirmed this, that as we age, our overall volumes get smaller as well, and the ejection fraction goes up. This phenomenon is also seen on the left ventricular side. So that's why it's important when we're reporting what's normal and what's not, we factor in the age and gender. And that's also been making its way into the echo literature as well with the 2015 Chamber guidelines. Now, is there a difference between whether or not we do axial versus short axis tracings of the right ventricle? And someone did look at this back in 2012. They found that there was actually very high concordance between axial contour measurements versus phase contrast imaging measurements, and short axis measurements with phase contrast measurements as well. So all in all, they all tend to agree. So overall, tend not to make a difference. I do want to make one caveat though, and this is just to remind our technologist. There is the case of the Epstein's anomaly where the tricuspid leaflet is very much the septal leaflet is very much apically displaced. And so in those cases, a long axis stack might be more advantageous than a short axis stack in terms of quantifying true RV stroke volumes in those patients. Okay. This is literature from 2014 showing reproducibility of different groups for various measurements. And as you can see here, it was only about 6% for EDV, 6 to 10%. A little more highly variable with end systolic volume. EF also a little variable. Mass we don't do as much, although if we did do that, we would tend to do that in end systole where we see more of the myocardial mass thickened. So, I put the slide up thinking of Dr. Quinones. This is why does it clinically matter, the so what question. Turns out our heart failure colleagues have known for some time looking at patients with RV function and prognosis, and this is in all comers in a set of about 400 patients, that once your RV EF falls below about 40%, that you do have increased cardiovascular events. So this is pretty important from that standpoint. In terms of its importance in different disease states, I want to go through a couple of cases with you. So we'll start with the first case. This is a 66-year-old admitted with chest pain. All right, so I'm going to pick on one of our MRI fellows, Yang. Yang, what do you see?
So I see a normal LV ventricular function. The RV looks dilated compared to the LV. You can see on the four chamber, it's a very brief RV diameter is diameter. And also appears hypokinetic, except that the apex, which looks more less hypokinetic, kind of dragged in by the LV.
What else do you notice?
So
I'm showing you delayed enhancement images on purpose.
So these are delayed enhancement images. We give selenium and then wait around 10 minutes or so to image Scott. So going these are short axis images on the top. Going down to the basal slice, we do see focal area of transmural infarction in the inferior wall, and also some in the RVC point. And then going down to from base to apex, and then on the three-chamber, on the long axis, the three-chamber, the four-chamber, and the two-chamber, we can see specifically the two-chamber, the degree of transmural infarction of the other thing we wonder is that in the four-chamber, although we typically don't see it, there may be some delayed gallium happening in RV.
So this is a case of an RV infarct, and you described it very well. That on the CINAGE, you can see that there are wall motion abnormalities in the lateral free wall, and it's more prominent in the inferior portion. Click on one of these and go through just to.
There's a tiny wall motion abnormality in the inferior wall of the LV also.
Yes, yes.
So it's interesting, from the LV side, it's a kind of a small infarct, but from the RV side, it's a pretty big infarct.
Yes.
Very interesting.
But here you can clearly see that there's normal viable myocardium in the basal outflow tract area of the RV. But compared to the inferior wall is enhancing. And so this is actually a great example of an RV infarct. So why does this matter? This is just the same case again. So this is a gentleman who came in with a completely occluded RCA. The incidence of RV mass index in context of inferior MI is about 20 to 50%. About 10% of those cases are less than 10% of those are hemodynamically significant. But the classic description that we often see for the fellows is hypotension, elevated jugular veins, and clear lung fields. Why does this matter? It turns out that when you do have a RV infarct, it does impact survival. And shown here is that when you have a LV infarct size, it doesn't impact the overall. It does impact the overall survival as well. Well, I'm sorry, not the survival, but in this case, the LV parameters. A meta-analysis looking at several studies have also found that in terms of mortality, cardiogenic shock, sustained VT, and advanced AV block, involvement of RV infarct was a significant predictor of all of these events across the field. So let's go on to the second case. 34-year-old female referred for a family history of sudden cardiac death. And I'm going to let Dr. Chomsky take this one.
So the LV size here is dilated with what looks like probably mild stomach dysfunction. The apex appears more severely hypokinetic, and the other segments have more kind of global hypokinesis. With regards to the RV stomach function, appears largely, I don't know, according to the four-chamber view, it looks maybe mildly depressed. If you look at the axial stacks, I don't appreciate any wall motion abnormality. There's no areas of akinesis or dyskinesis in the RV. There are no pseudoaneurysms, no real. That's by morphology.
What do you think of this view on the four-chamber stack higher up?
I mean, the longitudinal motion looks okay, but it's hard to assess the lateral ball in that area. But at least on the short axis, the RV does look there's some distribution, maybe on series 14.
Series 14, you said?
Yeah, actually, 14 or 12.
So this patient was actually gene positive for ARVC. And as part of our protocol for ARVC patients, we usually do a four-chamber stack to help supplement our short axis stacks. And you were very astute picking out the LV dysfunction. She actually suffered postpartum cardiomyopathy as her initial presentation, never quite recovered, and then was sent to us. And when it came out that she had a family history of sudden cardiac death, was also tested gene positive. The CMR was very helpful in identifying also RV dysfunction and regional hypokinesis in this individual. And delayed enhancements are not as informative here, although it can be seen. Okay. So one common referral we often get for CMR is ARVC assessment. And there was a 2010 update that's far more comprehensive than what I'm showing here, but this is simplified down, just showing what we need by MRI criteria. And by MRI criteria, for major criteria, regional RV akinesis or dyskinesia or dysynchrony is a must. You must have that present in addition to a dilated RV of more than 110 in a male or 100 in a female, or RV ejection fraction less than or equal to 40%. Okay. Notice that fibrofatty infiltration is not on here. So unfortunately, it was found that there was too many false positives with cardiac MRI in terms of fibrofatty diagnosis. And so that was taken out of the guidelines. In terms of its,
So in essence, now MRI and echo are looking at the same thing.
Yes.
Usually size and function.
Yes.
It shows that you probably have a better look at all the segments than what we get. But the concept are the same. You're looking for more dilation and dysfunction than infiltration.
Yes. So there's been some convergence there.
Yeah.
Yes. Shown here are the sensitivity and specificity of the cardiac MRI findings.
Would the gold standard being what, genes or?
Not necessarily, because patients can carry the genes and
Yeah.
may not.
So what's the gold standard when you're trying to do sensitivity and specificity?
That's a good question.
Yeah.
Clinical diagnosis.
Biopsy.
Clinical diagnosis, whatever that means.
Which throws on it EKG, throws on it clinical events, and
Okay.
potentially echo.
Yeah.
But as you can see here, the specificity of cardiac MRI for detecting RVC is pretty high. Sensitivity is not as high, but still pretty reasonable.
The normal RVEF by CMR is what?
That depends on the age and gender, but usually we say over 50% for sure is normal.
So if you have a case less than 50% EF, you will call it RV, mild RV stuff.
Yes, we kind of hedge, yes, because the new standards indicate that anything 55 and above, depending on age and gender, it should be more normal. But we do see a lot of individuals where we'll kind of hedge that. Okay, which brings me to another conundrum that we often come up with in the CMR world. In my third case, can I get the lights again? So I'll spare you some of the details. This is a 34-year-old who comes for research, and this is one of my imaging scans. Shameless plug here. We do encourage the fellows to get a little extra practice, and so if you want a free CMR, we can try to arrange that. But the thing you'll notice about here is that his cardiac chamber sizes are very generous. This is.
You do not have a scale on the image, so how are you judging the size? For us, we have a scale and we depend.
We actually do have a scale. So if you look at every single one of our images on the right side, we have 1 centimeter marks. I'm trying.
Not CMR.
It is not cooperating. Let's see. That's the previous case. But while this is loading, what I will comment on is that the chamber sizes are a little on the generous side, still within normal, but generous. And his heart rate is in the 50s.
But you know, that in itself, I think, is a very important piece of data that has not really been publicized that much. The fact that young people tend to have bigger RVs. And I can remember many times when young people have had an echo for palpitations or whatever. The echocardiographer reads it as dilated RV, and it triggers all kinds of expensive workups on that young man who has nothing. So I think it's an important thing to remember, that young people can have bigger RVs and not get all excited about it, because I've seen cases where, you know, the book has been thrown at a young person just because the echo report said.
Young
and
athletic.
No, he's talking about just young. Yeah.
Although this gentleman was also is very, very highly active. He does.
Yeah,
he
but
does a
your
lot of-
data suggests, indicates in larger numbers, even for just young people. if you're
But
athletic,
normal
that
values
makes it
that you
more.
can go by and say for this age, that is an acceptable RV size. I
Yes,
would
and
not
that's what I
put
was
it in
showing
large.
earlier with Dr. Macera's work from the UK that she published back in 2006. She provided data standards that we use. Although that's a more European cohort, and Mesa has put out some data on that regard. But the thing
I
you'll
think
note.
for the fellows, I mean, a good trick would be if you're doing a young person and you see a big RV, spend a little more time and do RV outflow, LV outflow measurements. And unless you see some really significant increase in flows, don't get carried away, because everybody gets concerned that they're missing sinus venosus ASD or something like that. But just don't throw in the report. Do a little bit of RV outflow measurements of flows, and unless you really see a QPQS that smells like a real, don't get carried away, because it's, I've seen situations where anxiety in the family, more tests done, and at the end there's nothing.
But you bring up an excellent point, Dr. Canones, because an issue that comes up with young patients and supposedly abnormal echoes is whether or not there's ARVC, and so there's often the conundrum of athletes' hearts. So when people are very well conditioned cardiorespiratory wise, they tend to have larger RVs, even above that of a normal population. They also tend to have a slightly lower EF, and in this population, they noticed a little increased myocardial mass. Mesa actually did look into their cohort, and found that when they looked at values adjusted for various factors beyond just age, sex, and race, that there was a trend that as your athletic performance, your exercise activity increased, and this is quintiles of exercise activity, there was increase in RV and diastolic volume that you can see here that persisted despite adjustments.
But that is related to the type of sports.
Yes,
So more with aerobic, not resistance training.
absolutely. But we see a larger stroke endoscopic volumes, and EF tends not to change as much, at least in this larger prospective cohort. Again, this is just showing similar trends. Athletic patients tend to have larger volumes across the board, and this is comparing to ARVC patients. One thing that was intriguing was that they did pick up delayed enhancements and more regional wall motion abnormalities, and so that's why being more systematic and making sure you don't overcall things is important.
But it looks like, even though you had statistically significant differences with the volumes, the real
Crossovers.
accuracy is the wall motion abnormalities, the delayed hyperenhancement, and the LV involvement.
Yes.
So the bottom three.
Yes.
We'll identify these cases from that.
But it does also raise a potential conundrum. Is there such thing as too much exercise? And some people have looked at biomarkers and found that, you probably heard of studies where they looked at marathon runners and found that there's elevated biomarkers of like troponin and BNP.
Yep.
And sure enough, when they looked at athletes, there was a study where they looked at 19 case reports / series studies and 14 athletic population studies, and they found that delayed enhancement was ascribed in these individuals. So SCAR does show up in these individuals. What it means prognostically, we know.
Picked up based on the case reports. Is that right? Not a group of patients that were studied.
So this
in
was both. This
single
was a
center.
systematic review where they looked at 19 studies looking at case reports, and then so there may be a selection bias there. You're absolutely right. But then they also looked at 14 populations where they just sampled these athletes, and there was still a pretty significant percentage of delayed enhancement reported in these individuals.
Yeah, and there was a J curve that was published about a year or so ago
Mm-hmm.
from a European, I can't remember which European country was it, but they basically, the J curve was, if you sit in your butt, do nothing except the TV control, you're up here with cardiovascular events, you exercise, it comes down. You overdo it, these crazy exercisers goes up again.
Yes.
And that was, I mean, they're talking population studies of big databases. So it suggests that there's something negative about the over-exercise.
Yes.
The people who are doing these triathlons.
There's talks
Marathons.
there's talks of more ectopy in these patients and possible arrhythmogenic events, and so this is one possible explanation for that. There is scar formation in these individuals. All right. Next case, I have a 67-year-old female with a liver cancer referred for valve assessment.
You're gonna take it all?
Hmm?
You're gonna take the whole out? Is that the plan?
I will try to wrap this up quickly. But this should be pretty obvious. The fellows, you should recognize what this is.
You don't need an MRI for this one.
Yes. Yes, I hope you do
It
not.
should be malpractice to order an MRI for this one.
Yes. So the liver cancer is carcinoid, and these are the classic fixed leaflets of carcinoid disease.
Is there a small effusion?
There's a small effusion as well.
You know, they've ordered quite a few for this. And I don't know if they want particular measurements, because in one case they were trying to, put a valve in there somewhere.
Yeah. Maybe
So-
for planning, if you're going to plan the surgery and need some sort of, I don't know.
So when I try to look for literature on using the tricuspid, trying to do tricuspid evaluation in terms of cutoffs and what have you, turns out there's really not much out there, and I'm hoping work that our very own Dr. Zan here is going to be putting together will help shed some light. There was one group in University of Chicago with Dr. Lang and company, where they did try to look at jet area, tricuspid jet area, and signal intensity. And my issue with this is that this is probably looking at more of a regurgitant orifice area, because I'm not sure measuring this area and measuring the signal intensity will work in an extreme severe case like in the carcinoid case, where you have a wide open valve.
Couldn't you get, in the absence of other regurgitant lesions, couldn't you just get the difference between RV stroke volume, LV stroke volume, and the difference is the tricuspid?
Yes, that is another potential way of doing that. The classic way we do it, though, is
Most carcinoid have a single valve lesion, so actually that could work just fine.
yeah. The classic way by MRI, though, is to take the RV stroke volume, take the PA forward flow, subtract the PA forward flow from the
Right.
systolic flow from the RV stroke volume, and get the TR. Okay. I won't go into this into the images as much, but just to accelerate things, the congenital heart group does recognize MRI as an extremely powerful tool for assessing RV and RV sizes and function. In fact, they do recognize in tetralogy of Fallot it does affect timing of repair, and it's just data showing that it does influence predicting change and recovery following pulmonic valve replacement. There's work coming out that suggests that RV mass to volume ratio may be also potentially predictive, and so some groups are. So one big group is looking into that. Another potential referral we often get is for pulmonary hypertension assessment, and there was a recent study in the Journal of Cardiovascular CT that demonstrated that increased diameter size did correlate with right heart cath measurements with increased mean pulmonary pressures as well. It also turns out that the amount of septal flattening can also be used to calculate mean pulmonary pressures.
How do you do that by MRI?
So what they do is they measure the angle. They measure the septal angle in systole.
Which angle? By the way, that was first probably by echo. The echo people have not picked that up, but the very first publications of that concept came from echo. And it's probably not a bad idea to apply that, but for some reason he didn't catch on, because everybody has a TR velocity, so why bother with this? But But I remember several years ago that concept came out, and it makes some sense that you're looking at the degree of flattening being an indicator of the difference in pressure between the two chambers. So. But what angle specifically did you measure?
It looks like from this diagram they're measuring the blunting of the septum itself.
Can you point to it?
This right here. But that doesn't make sense. It would make more sense to measure the angle at the hinge point.
Yeah. Interventricular septal angle.
Unless it's this obtuse angle between these two edges.
Yeah, but is it
And
summation of both angles, or?
I think it's a quadrilateral, I don't know, I could have the publication, but it's like a quadrilateral with four sides and this thing. And the closer that angle to the 180, the flatter it is, presumably. To me, I mean, you can see from our end why the TR and the PR jets, one would be more comfortable.
Yeah, we're
with
more
them
comfortable.
than
But the very first
this.
report of that concept actually came out from the echo literature.
Just to wrap a few things up, SCAR is predictive of prognosis as well at the hinge points, and so that's an important thing to look at. In terms of future directions, there are moves to try to do parametric mapping, so even more improved tissue characterization with high resolution 3D sequences. There's also free breath holds 3D cinase. So hopefully we won't have to do a 90-second breath hold that my volunteer, Dr. Khan, had to do to get a 3D cine. This has been reported to be acquired only over 4 to 5 minutes, so hopefully we'll be able to move to that. And I'm not sure if this will play, but there's also, I guess it won't. There you go. But there is a potential for 4D flow mapping as well, so 3D phase contrast flow as well. So in summary, CMR does provide excellent visualizations of the RV with accurate assessment of volumes and function. It has low variability, which is helpful for serial measurements. It permits assessment of RV myocardial infarction and tissue characterization as well. And new techniques are actively being investigated and potentially expanding its utility as well. Any questions?
So you said at the beginning you wrote an RV segmental map.
Yes.
Actually, it was a 17-segment map on the RV, including an apical cap. There's number 17, I assume.
A 17-segment RV?
Yeah. Is that what you report, a 17-segment RV?
No, we only report. We only report 5. There's basal. There's more of a basal anterior, basal inferior, mid, lateral, and apical.
So is that a CMR guideline?
There's no set guidelines, unfortunately, but that's how we characterize it, how we score it.
Well, the LV has a 17-segment. RV is pretty hard to imagine trying to report 17
Yes.
segments. And most people say there isn't anatomically an actual apex to the RV. There's a bit near the front that's beside the LV apex, but there isn't an apex. I'm just curious how you comment. It tends to be just free wall or globals or.
You're absolutely right. And as I mentioned earlier in the talk, the RV is extremely variable in terms of location and position in patients and its geometry. So it doesn't lend itself well to a particular segmental classification.
So, if I can make some comments. First of all, I think the echo assessments of RV is also a very important component, and I would suggest that we readjust the schedule of the conference so that Dr. Naga can have a real time. I mean, it would be unfair to ask him to give a presentation now.
My
It's not
apologies.
supposed to be a half and half. So we can look at the schedule and readjust it so that Sharif can give, because most of the stuff is done by echo, not by MRI. And we also need to learn how to do this as best as we can. That's a comment. The other comment is very important. When I look at the way we do it by echo and the way you guys do it, basically you have very fancy measurements and we have a lot of eyeball. But at the end, we're both struggling with the same problem.
Yes.
And this is the problem. There are 2 clinical scenarios that are critical for people taking care of patients. And neither one of you are giving us good answers, neither the echo nor the MRI. One scenario is acute RV failure, for example, after surgery. Is the RV dead or will it come back? Second scenario is the chronic pressure overload, pulmonary hypertension patient. You're planning a lung transplant Is the RV dead or will it come back? And those are two scenarios that you didn't touch and are critical for people taking care of patients. We don't care about the F. We can look at the RV and see that it sucks. Question is, will it get better or is it dead? And the same thing for acute RV failure. We don't need fancy measurements. The RV sucks. Will it get better or is it dead? So those are very important clinical scenarios that we need answers to. We need answers to both scenarios, either by echo or by you guys. So that's my comment.
And the acute situation you cannot probably address.
Probably you cannot do a CMR in an acute situation.
Yes,
So yeah, you forget.
little hard to do breath holds and. Yes. But yes, that is a very valid point. Hopefully, down the road with tissue characterization, we can get.
Well, maybe strain. I don't know. I don't know the answer, but I think those are two scenarios that we really need help. And these are daily clinical scenarios that we.
There is some
we have
growing work with RV contractile reserve measurements.
Yeah. So I think that's
That's
one of
not
the things
picked
that we
up
may
some.
want to either do some research on, and of course, since Dr. Naga is going to have an hour, a whole hour for RV,
Yes.
maybe he can put his thoughts on that too.
BP
Because these are
impressions.
common scenarios. We see them, not daily, weekly, and there's no good answer other than wait. And for the pulmonary hypertension patient, it's really, you have one crack at it, right, to replace the lungs. And if the RV is dead, you're going to be putting patients through a horrendous surgery. You're going to be using a lung from somebody, and then the patient is going to not do well because the RV was dead.
Also problematic with the HFrEF patients that are heading towards an LVAD.
Mhm.
How much of the RV dysfunction can improve
Yeah, that's the
or
other
may not
scenario.
improve. It's a critical decision on how to proceed with these cases.
So the fancy measurements are pretty, but they're not answering those questions.
Yes.
There is really nothing, I mean, when you go back to it, what we have seen here so far is RV volumes and EF.
Yeah,
There are
which
s-
we grant you. You guys do it much better than we do.
Yeah.
there
But
are s- there
that
are
doesn't
s-
answer the
there are
question.
some groups that are looking at stress perfusion, RV stress perfusion, as well as looking at RV function under exercise stress conditions. But
It's hard to do that when somebody has already a pH of 100 to start with.
yes. But I completely agree with you, Dr. Quinones. The echo is still first line, and should still be the first go-to test for evaluating all the patients. Thank you. My apologies, Dr. Naga.
Nice work, Dr. Naga.